All right, everybody. Thanks for joining us tonight. We are going to be talking about psychology's role in physical therapy and fitness tonight. A little bit about me. I am a neuropsychologist who consults with Whittier Rehabilitation Hospital. Been doing that for well over 20 years now. And I'm also have a private practice for both psychotherapy and neuropsychological assessment. My contact information is here. Feel free to reach out to me if you have any questions or comments after tonight's presentation. Here's the agenda. I'm going to break it down into some major categories related to psychology and its role. These topics include mind-body connection, motivation, goal setting, pain management, resiliency, social support. And finally, I'll touch on injury prevention and fitness at the end. I'll also intersperse case studies during this presentation to demonstrate how psychology and behavioral health plays a role in physical rehabilitation. Most of the, by the way, most of the case studies that I'll present originated as inpatients. However, as is almost always the case, patients discharge and require outpatient treatment as well. So I believe the case studies that I'll present are relevant to the audience tonight. And also during the case studies, I will ask for comments or discussion. Please feel free to unmute yourself, ask questions or make comments. And that's a good time also to ask questions if you have any questions with regard to the content that has already been discussed. All right, so let's start out with the mind-body connection. This topic seems so trite. I mean, the phrase is overused and oversimplified, but in fact, it is an ever-evolving topic, and it continues to advance vis-a-vis research and clinical studies. Suffice it to say that we cannot talk about comprehensive physical rehabilitation without discussing a person's overall mental health. So, with that said, whether it's someone who is incredibly resilient, dedicated, disciplined, and optimistic, and without any symptoms of a mood disorder, or someone who may be experiencing challenging symptoms of depression and anxiety, note that even here, as I mentioned, two common diagnostic labels, depression and anxiety, can have a very different type of implication on one's participation and involvement in physical therapy. For instance, someone who's experiencing predominantly depressive symptoms, low mood, minimal energy, a pessimistic outlook perhaps, they may be more prone to withdraw from physical therapy participation or have difficulty following through with in-person appointments or at-home assignments. Whereas someone with anxiety may be more prone to overdoing prescribed exercises or being reluctant to engage in certain activity because of fear, perhaps of pain or further injury. So you see, even in this very broad example of how depression and anxiety may differ in its presentation, it illustrates the importance of being aware of the nuances of someone's mental health and its impact on physical recovery and rehabilitation. Thus, the mind-body emphasis. Additionally, anxiety, depression, and even acute stress may negatively impact outcomes with specific symptoms. For example, chronic pain, which we'll talk a little bit more about in a bit, seems to be exacerbated with unregulated stress. So not only is the patient's behavior within the context of being depressed or anxious have an impact on the outcome, but the perceived experience of physical pain can be exacerbated by the presence of unmitigated stress. In fact, this highlights the importance of effective stress management and resiliency training for patients experiencing conditions that result in prolonged pain. And I'm going to talk specifically about resiliency and some of the factors imperative in resiliency training. Let's move on to motivation here. Motivation refers to the internal or external drive that prompts someone to act or behave in a certain way. It's the reason behind an individual's actions and goal-oriented behavior. Motivation can stem from internal factors, which we call intrinsic motivation, such as personal satisfaction, or external factors, or extrinsic motivation, such as rewards or recognition. In physical therapy and rehabilitation, we hope that our patients have a strong intrinsic motivation. But sometimes, in the absence of that intrinsic motivation, external factors move us towards an important goal. Recently, I had a patient with sudden and profound depressive symptoms. Previously, he was a high-performing businessman and self-described dedicated husband and father. His only daughter had special needs and required a good deal of attention. Unfortunately, the patient's depressive symptoms were so severe that he could not motivate himself to participate in physical activities that would bring him to his previous level of fitness and, more importantly, improve his mood. One external factor, however, that did motivate him was his daughter's perception of him. So I utilized that external motivating factor in the initial sessions of psychotherapy until we could establish a more intrinsic motivational factor. So sometimes we do need to rely on those external motivating factors. A little bit more on motivation here. As you all know, motivation is a huge part of the formula for successful physical therapy outcomes. Unlike participation, unlike medications or surgery, participation in physical therapy is absolutely crucial to improvement. Therefore, I think it's an important topic to dive a little deeper into. So I'm going to share with you here the stages of change model, or something called the trans-theoretical model, which describes the process individuals go through when modifying behavior. These stages are distinct and usually go in order, but at times there is some crossover. But by and large, people who implement changes in their life go through all of these phases relatively in order. As clinicians, it's important to recognize where a person is on this continuum. So we'll start with pre-contemplation. This is when someone is not even thinking about making a change. It's difficult to engage anybody at this stage to participate in something that requires effort. For instance, physical therapy, right? A good example might be somebody who does not relate to his or her functionality with regard to engaging in physical therapy. So maybe someone who is just hoping that, Motrin and pushing through their pain is going to be the way to go. All right. So that might be a good example of pre-contemplation in this context. Contemplation is when a patient is beginning to think that it might be a good idea to implement some changes that would improve the quality of their life. In this case, let's say an individual would decide actively participating in physical therapy may have positive outcome that is worth the effort. Okay, so they're really kind of getting into thinking more actively about it. And then preparation is when an individual actually takes the action. They will collaborate with the creation of a plan to assist in their goal. This is really kind of where we start to enter the physical therapist's sweet spot. the patient is open to ideas and actions to get them to a better place. And then there's the action stage, is when a person themselves actively implements behaviors. This stage, the patient takes responsibility for continued care on their own. For instance, someone who engages in physical therapy exercises at home without undue coercion. And then there's the maintenance stage. This is when an individual works to sustain the change over the long term to prevent relapse. This stage involves integrating new behaviors into long-term lifestyle changes. And finally, not always, but sometimes, people experience a relapse stage in which individual may stop doing the things that were positive and revert to previous behavior patterns. This may be when a patient needs to bolster a booster session or additional physical therapy after the initial sessions. So you can tell by the definitions of these stages here that this model is relevant to many different endeavors, okay? In fact, the trans-theoretical model, the one we're looking at here, was initially conceptualized in the field of addiction, but it relates very well to many other behavior modifications. It's important to know what stage a patient is in at the time of engagement. For instance, if a patient is in the contemplation stage, they still need some convincing, while someone in the action phase is already sold, and they are the ideal stage for professional oversight, information, and assignments. So try to keep this stages of motivation, stages of change with regard to the trans-theoretical model in mind when you engage a patient, particularly for the first couple of sessions. Okay, let's talk about a case study here. So this is a 54-year-old woman who's overweight, diabetic patient who's amputated above the knee on the right side. She's got years and years of unhealthy behavior, poor eating, limited exercise, limited social exposure, and some indifference, in fact, even about continuing to live. Not actively suicidal in any way, but just kind of blasé about continuing to exist. Okay. So what are some of the things that we want to be thinking about in a case like this? Feel free to jump in. If not, I can talk about it. Remember, in this situation, I put down some strengths. You want to highlight strengths. So this patient is intelligent, articulate, insightful, a non-smoker and non-drinker who enjoys cognitive activities such as reading, puzzles, and educational pursuits. Her challenges is that she has kind of limited resources, limited exposure to physical activity. She's got obviously these physical limitations now that she's an amputee. So there's some things that we need to work around. Okay. So what I'm thinking with regard to this patient are many different things, but one is kind of the stage of change she would be in. And she's kind of in this contemplation stage. She's been living this kind of lifestyle for such a long time. And she is very comfortable being cognitively engaged and sitting in her home, essentially isolated, days on end, and not really taking care of her physical body. And so she is now contemplating whether it is worth the effort to improve the quality of her life. And in fact, in her case, even continuing to live, because she realizes that she's not going to be long for this world if she doesn't make some significant changes. So knowing that she's in the contemplation stage, I would be implementing some things to kind of convince her to get motivated to make some changes in her life. I would try
Chris,
to, yes, please.
when we see somebody like this in an inpatient physical therapy, situation,
Mhm.
aren't they, isn't it been kind of fast forwarded that they almost need to make changes because they're in physical therapy because they've lost their leg, really, so
Correct.
it's almost like if we need to convince them to make changes, it's going to be hard for us to move forward in physical therapy, really. But um, if they didn't get the leg amputated, they wouldn't be doing physical therapy. They wouldn't be contemplating making some changes in their life.
Yes and no. I mean, that's a really great point. And in fact, you reminded me of something else is that, really sometimes, especially being an inpatient in a situation like this, it can really move someone across the stages of change more quickly because it could be a wake-up call, right?
Yeah,
In
that's what
her
I was kind
case,
of thinking. Yeah.
in her case, though, she was literally transferred by ambulance due to a diabetic incident, went to an emergency room, was admitted for acute care, and then sent directly to Whittier. So there really wasn't a lot of choice in the situation. So we're still, in some ways, in that contemplation stage because she's like, okay, this is where I am right now. Um, do I really want to continue? Do I really want to start a process that will take a lot of effort to make changes in my life? So your point is really good. And I think it really differs from patient to patient, and you have to kind of assess that at the moment. Thankfully, at least at this point, she really has seemed to make some headway in terms of committing to some things, both while in-house, but also hopefully when she goes home. So also what I'm thinking about with regard to her are just some more cognitive behavioral interventions, which I'll talk a little bit about later on in the slide deck. Some things with regard to depression and her indifference, her kind of apathy, maybe trying to figure out what some of her cognitive structures are with regard to those feelings of indifference. Maybe, even digging into past experiences as to why that has occurred for her. And adapting to the amputation. Even though she's not a particularly active person, it still is going to be a major adjustment for her just getting around her apartment. And motivating her for lifestyle changes. We discussed that, as well as, in her case, encouraging social contact. She really has very limited social contact as well. And we're going to talk about how social interaction plays a role in overall health and outcome within physical therapy as well. Okay. So we are on to goal setting. Okay. So the trans theoretical model that I just discussed leads us perfectly into this next topic, which is goal setting. Goal setting is an integral part of achieving a desired outcome. So it seems simple enough, but frankly, it can be complicated. A goal that is too lofty and unattainable in a short period of time, it may be a deterrent for action. While goals that are too simple or easy may lead to distractibility or a limited progress. So getting that sweet spot for goal setting is crucial. In most cases, it's useful to have both short and long-term goals so the patient can see the forest through the trees. But using that analogy, also recognize the trees that you need to get around in order to get to that ultimate goal. So having the shorter term goals with the longer term, bigger picture is important. So as noted here, self-efficacy is an important factor. We want patients who have a high level of internal motivation, as well as a perception that their actions will result in positive outcomes and that they can control those outcomes, most importantly, right? And as a clinician, it's important to set reasonable goals and celebrate successes, particularly with some patients. That's very important. And to have concrete ways to demonstrate when a goal is achieved. I encourage patients to be involved in their rehab to ask specific questions of their treatment team about what the benchmarks are for them getting to the next level of care and eventually being discharged. It's remarkable to me how often patients do not know the answer to this question. So really identifying what the concrete benchmarks are for each stage and what the ultimate goal would be. That leads us to another case study here. Again, feel free to jump in. This is a 57-year-old male. Let me just my notes on this case. Work-related injury requiring lower back surgery with fusion. Patient is an engine mechanic, spends hours a day on his feet in awkward positions, standing on hard surfaces. He has 2 children in high school, hoping to attend college. The patient feels his duty is to provide them with the education he did not have. He is an impatient, I am not impatient with his pace of recovery. And the pain he's experiencing is overwhelming at times. He is on opioids with, of course, the intent of weaning them off soon with his medical team. So a lot of factors to consider here. Certainly the occupational stress that he will face when he does decide he is ready to go back to work. That could be a setback for him physically, pain-wise, and psychologically. So we want to keep an eye on that because he is in a high physical stress occupational field, okay? Goal setting will be really important for him. He will likely be very ambitious in his goals. He's got this kind of background noise going on about him being the provider of the family and wanting to make sure he supplies his children with the financial resources they need to move on. So we're going to need to put that into some perspective to make sure that he's not doing further damage to himself in speeding up his recovery process trying to get to recovery too quickly. So maybe a methodical approach to this, in conjunction with the physical therapy plan. Cognitive behavioral therapy to address, self-induced pressure with regard to he and his perception of himself with regard to his family. And again, the final sentence there is kind of a doozy, right? We got to be very careful about dependence on opioids or any other pain-killing medication. So, he could be at high risk just by the nature of the fact that he is so driven with kind of the ends justifies the means sort of mentality. So we just want to keep that in mind. Other thoughts on this case that strike you as really important? Okay, hearing none, we're going to move on to the next topic here, which is pain management. Okay, well, I don't think that we could have a comprehensive discussion about psychology's role in physical therapy if we did not discuss pain. Physical pain is almost a given in your line of work. Psychologists are trained to help people manage pain. Usually we are called in, after it becomes a chronic issue. However, even acute pain for longer periods of time can be overwhelming and restrictive. And there are things that can be done in physical therapy setting that will be helpful. For instance, there's so many videos and instructive websites and easy to use applications on informative methods for meditation, breathing exercises, visualization. These are all exercises that can help a patient manage pain better, tolerate their pain, and ultimately achieve physical therapy goals. Now, there are definitely cases where you want to bring in a behavioral health expert, a psychologist, who might be needed for more extensive cognitive behavioral therapy if pain continues to interfere with motivation or goal achievement. But I encourage you to lead patients to these more accessible options as a first line of assistance. Pain management is a complicated topic, and we could spend a whole hour just talking about that, and we wouldn't even touch the surface. But something to know is that there are a lot of new resources out there. And this whole idea of activating the parasympathetic nervous system through meditation and like activities, there's a lot of good resources out there on this now. Okay, throwing another case study here, throwing them at you fast, just to get you thinking about these things. If you want to chime in, feel free. 24-year-old male with multi-trauma due to a motorcycle accident while under the influence of alcohol. He meets the criteria for alcohol use disorder and maybe under-reporting other drug use, kind of not quite sure there, including cocaine and methamphetamines. We know that he's used them. We're not quite sure how much. He's not really, we're getting conflicting reports from him and family members. Had a head injury that may be playing a role in judgment and motivation with regard to his rehabilitation process. And just a note here that this is a whole nother topic. What I am involved with this as well, are the cognitive issues. Tonight, we're focusing mostly on the psychology or the kind of the emotional response and behavioral response. But remember, cognitive issues come into play with many different patients. I see a lot of them on the inpatient side. Strokes, head injuries, hypoxic events, neurodegenerative diseases can all play a role. And neuropsychological testing and capacity assessments can be crucial for safe rehabilitation. So I just want to put that note in here. It's not really our topic tonight, but it is a factor. And certainly for this case, it would be play a big role. Additionally, when we're talking about other psychological issues, certainly the, addressing the alcohol and perhaps other drug use issues may be an important factor for this 24-year-old man. Initially, though, he is in a great deal of pain due to multi-trauma. They are managing him with opioid treatment as well as other pain medication, and for good reason. Yeah, he really was quite banged up. So these are things that, we have to consider. Now, with this patient, we also want to think about, figuring out where he is with regard to the stages of change and how motivated he is to change certain things in his life in order to get him in a better place and have him in a safer place and, get him back to, work and functionality. He's got a long road ahead of him just because of the nature of his injuries, but certainly ongoing psychological and behavioral health involvement, I think, in this case is very important. Now,
Chris,
unfortunately, with some patients, the motivation factor to being involved in psychotherapy may be limited. Yes, please, go ahead.
I was going to say that this is like one that I was thinking of. His motivation for getting through inpatient rehab might be getting out so he can get back to his drug use, which is really the initial, what he needs to really make some changes for. And I don't know where that plays into your, motivation, the stages that we were talking about earlier. But it could mean that his motivation is what got him in there in the first place. I've seen this before myself. This person gets out of rehab, they're going to go for a drink. Which kind of got him may not have got him in there in the first place, but certainly plays a role into it. So it's kind of tricky. You try to,
It is tricky. And I think, in a case like this, you have to kind of set parameters and kind of realize what the role is of the team and, ultimately our role is to, get him to a place medically where he can get to a higher level of independence. And after that, it becomes more difficult to, determine, what he might do with that level of independence, to your point, That's where I think it's really important to have a nice transition from, say, an inpatient level of care to an outpatient care where he gets the full range of services, including ongoing behavioral health support and perhaps, addiction treatment and that sort of thing. And again, to your point, his level of motivation may be questionable, cognitively too, when you're talking about somebody who's 24 years old versus even 34 or 44 years old, sometimes maturity comes into play in terms of long-term outlook and, being able to plan for, the long-term benefits of behaviors versus, short-term, what's in it for me now sort of thinking, that can be pretty common with younger adults, particularly males. Really good points. Thanks for that. Okay, so we've talked a little bit in some of these case studies about barriers, specific barriers that have come up in these cases. There are many challenges that present themselves during the course of rehabilitation for many patients. Probably one of the most common that I encounter, I'd be interested to hear if others have different opinions on this, but is hesitancy and underperformance in physical therapy due to factors related to re-injury or loss of independence. We see that a lot at Whittier just because we have a disproportionate amount of patients who are older, and that whole idea of losing their independence is a real raw issue for them. So when these factors interfere with goal achievement, it's important to take time to assess and treat these barriers. Sometimes less is more. I'm thinking now, outpatient physical therapy even, taking the time to discuss specific reasons for a reluctance to participate or to do the things that you're asking them to do, it can pay dividends in the long run. If you just take that time to, instead of doing that one extra exercise, take the time to actually have that discussion. Sometimes all that is required is a simple conversation between the physical therapist and the patient. Other times, consultation with behavioral health experts may be helpful. So, just keep that in mind that sometimes less can be more. Okay. Another case study here. This kind of goes along with that theme. 68-year-old female with gait issues, fear of falling. She has fallen a few times. Very anxious, overly analytical person, sedentary because of this fear, not sedentary by nature, but sedentary because of this fear of falling. Complains of vertigo, uncertain and tentative movements, perhaps some post-stroke deficits in visual spatial abilities, so neuropsych involvement there. Some of the things that I'm thinking about here in this case is, directly identifying the fear, breaking down the logic behind the fear of falling, even fear of falling with physical therapy assistance, so it became sort of a irrational fear. Like there were people there protecting this person from falling, but yet she continued to have this very highly anxious response to the physical therapy process. So one of the things that we think about in this case is something called systematic desensitization, where we try to initially just through visualizing a higher level of anxiety provoking situation. So we may have the patient visualize themselves, say, just sitting on a bed, thinking about getting up, and then maybe sitting out of bed with the walker, thinking about pushing themselves up, and then going through the process of actually getting to the walker position, and then maybe transitioning to an assistant who will help them walk, to transitioning to a cane, to walking unassisted. So, you get the idea. It's visualizing this, and the whole time they're visualizing this, walking them through relaxation exercises that try to deactivate the sympathetic nervous system and activate the parasympathetic nervous system. In other words, getting them to relax while they're visualizing these very uncomfortable scenes in their mind. And then you take that visualization and then you start to do the systematic desensitization in real life. And so this might be where a physical therapist and a behavioral health expert might work together while the patient is actually doing the exercises to get them to the point of where that, anxiety will not be overwhelming and really interfering with, no pun intended here, the next steps of their rehabilitation. Okay, so visualization is a good place to start there, but then when it comes to real life exposure, which will be required in order for the person's not going to get better from a physical therapy standpoint without actually doing the exercises. Okay, so that's an interesting case as well. We had some success there with her. Questions, comments on that case? Okay, so let's talk a little bit about resiliency. This is, I guess, just defining resiliency. It's really kind of the ability of an individual to withstand, adapt to, or recover from adversity, stress, or challenging situations that involve maintaining or quickly repairing psychological health despite facing difficulties with the ups and downs of life, and of course the ups and downs in life are parallel to the ups and downs of a rehabilitation process, right? Even more so, right? Probably even more so highlighted in a rehabilitative setting, because a bad day in rehab is very disturbing for a lot of people, because it seems like it's two steps backwards and one step forward. So one's ability to be resilient in a rehab setting is important for continued goal achievement. I think of resiliency as kind of the in vogue term for what we used to call stress management. It's the ability, really, again, to effectively deal with challenges and setbacks that are just part of life and certainly part of recovering from a physical injury. So let's dive a little deeper into resiliency. These are the essential factors that I cover when I'm doing resiliency training. I think they're the accepted. You could probably add a few here, but these are the ones that I feel are kind of the core of resiliency training. And it's really kind of life management if you think about it. Generally, I break it down into 6 integral factors. Sleep hygiene being one. There is so much research right now being done on the importance of sleep and overall fitness and health. And the studies keep coming, but the essentials remain the same, and that is most humans seem to do best on 6 to 8 hours of uninterrupted sleep. Achieving that uninterrupted sleep is the challenge, of course. Things like awareness of caffeine and alcohol use. Sunlight regulation is getting a lot of attention now with regard to sleep regulations, and sleep structure. Eating restrictions towards the later part of the evening as you get closer to bedtime is a big topic of research now. And then the whole bedtime, or I should say the sleep milieu. So, a very dark room with a cell phone maybe away on the other side of the room or even out of the room, better yet. Exposure to blue light close to bedtime, not a good idea. So all of these things. So sleep hygiene is one of the things we cover with people when we talk about resiliency training. And then there's nutrition, again, a topic with so much more information now available to the public that is almost overwhelming. But again, if we simplify this, it comes down to decreasing kind of the processed foods and particularly sugars, refined sugars, and having a good balance of protein, fiber, carbohydrates, and fats. Again, with regard to stress in particular, sugar, caffeine, alcohol, other drugs are all factors. And I'm putting these into the nutrition realm just because they're things that we consume. Obviously, alcohol and other substances may not have nutritional value, but they are things that do impact our overall health. Okay. And then physical fitness, the research again continues to mount on the importance of regular exercise and health, as well as mental health. In my clinical experience, a good exercise regimen, if we can get a patient to do it, is in many cases as effective as any SSRI that's out there. There are certain people that absolutely need and benefit from psychotropic medications, but physical fitness or having a fitness routine can go a long way in improving mood and overall mental health. So it really can't be overstated how powerful an impact regular exercise routine is on overall health. Now, it's a little complicated with regard to the physical therapy, for you all, depending on the level of impairment that you're working with. They may be restricted in terms of what they can do with regard to fitness while they are actually recovering from an injury. But you get the idea. The idea is, hopefully that person can rehab to the point of being able to regain their physical fitness or attain it for the first time. And again, that goes a long way with injury prevention too down the road. So also going down here to number 4, hobbies and activities that allow us to be completely engaged in that activity is essential for cortisol control. And as we talked a little bit before about that regulation of the sympathetic and parasympathetic nervous system so that we can kind of get into the zone, if you will. So having good hobbies and activities that are healthy and provide you with, good vibes, if you will, is really important. Social interaction, communication, I kind of lump these together. They're slightly different, but they're related, particularly as people age. And again, this is important for a lot of our population at Whittier. We get a lot of older adults, and it is a big factor in all causes mortality. So yes, people do die from loneliness. It is a factor. So thinking about that, you probably didn't learn that in physical therapy schooling, but the bottom line is it is an important piece of the long-term recovery aspects of a lot of our patients. So, and then finally here, number 6 is downregulation. The idea of downregulation is figuring out ways to activate the parasympathetic nervous system more regularly during the course of a day. So I'm encouraging a lot of my patients to do downregulation activities interspersed throughout the day. So, just take 10 minutes. Take 10 minutes away from the phone, away from the computer, and try to do a mindful activity, whether that's a meditation or relaxation exercise. And yes, I do have them use apps or YouTube or have somebody guide them through that process because it's easier for some people to have someone else guide them, even if it's electronically. So I do make that rule. They can use their phone or an electronic device if it is helping them activate that sympathetic nervous system or down regulating during the course of the day. Interesting study that came out last year, I think, that said, if you take, interspersing, getting down regulation to occur within 10-minute intervals at least 3 times a day improves, number 1, our sleep. So It tends to improve our sleep if we're doing that on a regular basis. I think it's just our body's ability to kind of get into that parasympathetic mode. If you're doing that more regular during the day, it makes sense that you're able to do that then at night when you're ready to really shut it down and get a good slumber in. Okay. So I talked about social support with regard to resiliency, but the topic really is worthy of its own slide. You know, strong social support systems improve adherence, motivation, and confidence. So if we know this, it's important to consider it in our treatment plan. Do people have the resources to hire a fitness coach or, after physical therapy ends, or do they have a friend who may be interested in maintaining fitness or overall health? Is there a community organization that they can go to on a regular basis where they can get that social support? Whatever it is, we know it's crucial for maintenance and relapse prevention, and it's worth talking to your patient about. If you have some downtime while you're doing some of the exercises, these are really good questions. Hey, what's the plan? Do you have a plan for keeping yourself active after this? Or if they do have that plan, it seems well-founded and it's it's more isolated, that's fine if they want to continue to do that on their own. But that social piece might be a separate factor. Hey, you thinking about going to the community center to play bingo on Thursday nights? Sounds silly. It might not sound like it really is related to physical therapy, but you know what? It is, I think, related to ultimate overall health and wellness down the road. So it can be a preventative measure. Okay, I covered most of this just now. So we're going to talk a little bit about injury prevention and long-term fitness. I think it's important to consider that part of our job as clinicians in the healthcare field, all coming from it from different angles, but I think we all play a role in encouraging lifestyle changes or maybe lifestyle maintenance. There's a lot of patients who are doing a great job. We just want to keep them doing that. With the idea of promoting long-term health and fitness, educating patients on the psychological resilience, some of the stuff I talked about before, and the importance of rest, self-awareness, stress management to promote healthy behaviors is an important part of the big picture. Again, here, there are so many resources available online through podcasts and easy-to-use apps that I strongly encourage patients to continue their journey through the use of these resources. I try to check them out, I think some are better than others, but really there's a ton out there. And, a lot of it is really good stuff. And in most cases, something's better than nothing. So I'm not too worried unless it's like unless I'm working with a kid who's, easily influenced by things on social media that might be negative or might have poor health consequences for them. But for most adults, I can say, go out there, check it out, see what's out there, see what fits for you. What resources might be helpful to you? Okay, so I'm just about to the end of the presentation, so we have some time here. We covered a lot in a short period of time. Again, I encourage you to open your mic if you have any questions or comments at this time. Okay, I think Joanne might have some evaluation tools she may want to put on the slide here. I'm just going to thank you very much. Also, go back up to my contact info if you are in need of that.